Yeah, hello, everyone. It's really nice to be here, and Michelle and I are excited to do this. Uh,
Lovely.
we have been talking about vibrant uh, technology and vibrant tests since the day we learned about them. And I'm happy to go on record now here and to give you some of the pearls that we've learned. So in the next couple of sessions, we're going to do a little bit of geeky technical information, but I know you're already getting a lot of that. And so it's not like we have to educate the uneducated. So I'm going to just throw some pearls out every once in a while that we've learned, and Michelle will do the same. And then we're going to throw in a bunch of case studies of what we've done with patients, what tests we've done, how we interpret them, what protocols we've given them, and what happens when you retest. So that's the plan here. And please feel free to type in your questions, as Sarah said, and uh, we'll do our best to either answer them now or during the Q&A session. So with that, I'm going to share a screen. I asked Michelle if I could start. You know, usually it's ladies first, but I thought I'd just give you a little background. So let me click a couple of slides here and get to our screen. There we go. So let's just move along here. And I'm going to start with this big picture concept. Why are we even thinking about testing? So many of you know Professor Alessio Fasano. I mean, this is the guy that identified the mechanism of how leaky gut occurs back in 1997. He and his team and have been publishing on this now for over 20 years. And if you look at his credentials, professor of pediatrics at Harvard Medical School, professor of nutrition at Harvard School of Public Health, chief of pediatric gastroenterology, director, mucosal immunology center at Harvard, director, celiac research center at Harvard. Any one of these positions is a lifelong goal and high five achievement for the top people in the field. Look how many of these positions this guy has. That's how unusual a thinker he is and how clear-headed he is in his explanations and in his publications of what he and his team are discovering. So we think he'll win the Nobel Prize for this because, as you all likely know, a leaky gut is the pathway into the development of autoimmune diseases. And for those of you that you find your arms crossing right now, as I say these kinds of concepts, I really welcome your skepticism. And I hope everyone here will be skeptical of what we're talking about. Don't just take it at face value. Skepticism means, I'm not sure I buy this. I'm going to look into it a little further. Cynicism means, I don't buy that. That's a hogwash. I'm not wasting my time. So if we can stimulate skepticism, I'm really happy because Vibrant's got a great clinical services team that can answer your questions and you call back again and again and again and just be a pain in their butt until you've got clarity as to what they're trying to, how they're trying to answer your questions. And they'll send you studies, they'll give you the references. But when you get clarity, I would wager that every single attendee will recognize this is something that I need to put a little time into and learn more about. So this paper that Fasano and his team published earlier this year, you know, guys like this, they never exaggerate. They can't because they know that they're misquoted quite easily. Look at the title of this paper. All disease begins in the leaky gut. The role of zonulin and zonulin-mediated gut permeability and the pathogenesis of chronic inflammatory diseases. So here we have the chief of pediatric gastroenterology, the director of the mucosal immunology center at Harvard. Now, what does that mean, mucosal immunology center? That's the lungs, that's the gut, that's the blood-brain barrier, where there's mucosal barriers. And he's the director of this at Harvard. And he's saying all disease begins in the gut. And what he's telling us is that there's growing evidence that there's 5 pillars in the development of chronic inflammatory diseases that he references here. Gut permeability, a systemic immune system response producing the inflammation, altering of the gut microbiome that sets up the gut permeability, your genetics, and exposure to environmental triggers. And he refers to it as the perfect storm. I love this photo because as you do a deep dive into this world that we're going to introduce you to today, perhaps a little deeper, is look at this guy standing there, hands in his pockets, left foot bent up and left knee bent, foot resting on the back wall there, just as comfortable as can be in the middle of chaos. When people develop chronic inflammatory diseases, they're in the middle of metabolic chaos. So how do we help our patients? How do we help our clients in getting out of this perfect storm that they find themselves in? Because all chronic inflammatory diseases begin in the leaky gut. So how do we help them? And of the 5 factors, genetics, you can't do anything about that. That's the deck of cards you were dealt coming into this world, right? And we all know it's epigenetics. So what does that mean, epigenetics? It means the middle 3. The environmental triggers, the altered gut microbiome and intestinal permeability that we have complete control over. Sometimes it'll take you 6 months or a year to really dial it down for a patient because they are so complexly out of balance, but we can do it most every time. We can do it. We can bring more balance to each of the 3 in the middle. And the systemic immune response, when macromolecules come through the permeable intestines into general circulation, and your immune system trying to protect you produces antibodies to those macromolecules, we really don't want to shut that down. So your immune system's trying to protect you. We may need to calm it down temporarily to reduce pain. So symptomatic pain relief, of course, but that's not going to bring long-term results. The long-term results come from the middle 3. And in those middle 3, the one we're addressing here primarily today is environmental triggers. That's the primary one. There's more to learn, of course, but we're going to talk about the value of these particular tests when looking at environmental triggers. Fasano tells us that the 2 most powerful triggers that stimulate zonulin release and intestinal permeability are LPS and gluten. These are the 2 most powerful triggers. Gluten and why? Well, we're not going to go into the physiology today. That's in our CGP course, our Certified Gluten-Free Practitioner course. But gluten is misinterpreted by the zonulin pathway as a potential harmful component of a bug. That every time, no, excuse me, I can't say that. What the science tells us is that every human, when exposed to gluten, activates toll-like receptor 4 in the proximal part of the small intestine, which is the signal transducer to increase zonulin secretion and increase innate inflammatory response. Toll-like receptor 4 is the defense mechanism, the sentry, standing guard that our ancestors had, because they're foraging for food. And what do they do when they find something? They smell it, they taste it, and then they eat it. But if they can't taste the pathogen that's in the water that they're drinking, and hydrochloric acid doesn't kill the pathogen, and it comes out of the stomach into the proximal part of the small intestine, toll-like receptor 4 gets activated immediately, trying to protect you. Activating zonulin, increased zonulin secretion, opens up the tight junctions, and water comes into the lumen of the intestines to flush the bug out. You get diarrhea, you get loose stools. That's the primary purpose of zonulin secretion. And it's activated by toll-like receptor 4 that is activated when the body thinks a pathogenic bug has gotten into the proximal part of the small intestine. Now, I think I forgot to put the science in here. Maureen Leonard at Harvard did a review in 2017 of the literature on this topic, and her conclusion was, how did she say? I'm trying to think of how she said it. Zonulin increase, and I'm going to have to ad lib it, I don't remember the exact words, but increased zonulin secretion occurs when humans are exposed to gluten. Every human exposed to gluten increases zonulin secretion, increases transient intestinal permeability. Every human, every time. Well, what does that mean? Mrs. Patient, you have an entire new body every 7 years. Every cell in your body regenerates, except for your teeth, every other cell. Some cells are really quick, like the inside lining of your guts every couple, 3, 4 days, depending on what study you read. Some cells are slow, but the lining of the gut is very, very quick. You eat toast for breakfast, activating toll-like receptor 4, because your body misinterprets this as a microorganism. You increase transient intestinal permeability. You have a sandwich for lunch, toll-like receptor 4 gets activated, zonulin secretion, you increase transient permeability, but it heals. You have pasta for dinner, increased transient permeability, but it heals. That's transient intestinal permeability until one day you don't heal anymore. And that happens when you're 2 years old, 22 years old, 92 years old, and we call that pathogenic intestinal permeability, the leaky gut. It's no longer transient, right? That's called loss of oral tolerance. So the cue is, well, what causes the loss of oral tolerance? That's the $1 million question. And that's what we spend a lot of time in our online course and all that. But that's not for today. It takes way too long. But that's the mechanism. All humans develop transient intestinal permeability when exposed to gluten. And it's not just gluten. It's other proteins of wheat, such as the amylase trypsin inhibitors. They are more powerful than gluten in activating toll-like receptor 4, zonulin release, and the innate immune response with local inflammation. Interferon gamma, NF-kappa B, IL-1 beta, all of those increase also. When you read the literature, you go, oh my God, how come I'm not sicker? Because I've been eating wheat my whole life. It was transient. It was transient that the healing reserves that you have, your organ reserve of the gut is stronger until it's not. And when it's not, now it's not transient anymore and you don't heal. Now you get the pathogenic intestinal permeability. Now that's an hour to 2 hours of discussion that we do with study after study after study, so you really get it, but this is just the summary here today. Now, this was one of my first mentors, and I put a picture of Dr. George Goodhart in here because he impacted on us so profoundly. On weekend seminars, Sunday mornings, it always starts the same, 9 o'clock Sunday morning. George gets up on stage and he would say this: one of the things I like to do on a Saturday or Sunday or any day is to ask for help from where it all comes from. I'm sure there's someone who can do this better than I can, but if you'll bear with me. And then he would bow his head and say, dear Lord, thou great physician, from whom every good and perfect gift must come, give kindness to our hearts, intelligence to our minds, strength and skill to our hands, so we may help our suffering fellow man through our chosen profession. We ask it in thy name, amen. And then he would say, and if anyone doesn't like it, it's too bad, it's my football, right? And then he would talk for an hour, philosophy, every time, didn't matter what conference it was, always. The philosophy of being a healthcare practitioner, of activating healing energy. And one of his biggest, and I have hundreds of hours with George at the Marriott Hotel at the airport in Detroit, which is where he lived. Everybody flies in, and the conference room in there has a wood stage, and he'd be up on stage, and there's a little podium there, and he would talk to us, and he would always do the same thing. He would lift his right leg up in the middle of a sentence, cock his right arm, and go, "Why, doctor?" and slam the stage, and the wood stage will just vibrate. We all jump a little. He was trying to drill it into us. Why does the person have what they have? Not just how do we bring symptomatic relief, which is important, and most of the conferences was focused on symptomatic relief, but why do they have what they have? So it doesn't come back again. And one of his messages was always the same: test, don't guess. And he would teach, this is back in the 70s and in the 80s, ranges of motion. And Dr. George was a chiropractor. So he'd check a patient's range of motion, do a cervical adjustment, and then check it again. And oh, I can turn more, or oh, I can bend over more. And just the little things that you can do to help demonstrate to the patient that this is going to be beneficial. Yeah, you still have your pain at the moment. It's going to get better. And they would see something of getting better. Now, carry that forward to today, and you do a series of tests to identify a patient has elevated antibodies to gluten, elevated antibodies suggesting intestinal permeability, elevated antibodies to myelin basic protein, the mechanism that eventually can manifest as MS. And they may have 10 markers positive in the NeuroZoomer Plus that looks at 48 markers. They may have 10 positive. And okay, so there's a lot of inflammation going on in their brain right now. You retest in 6 months and they're feeling 30, 50% better. The numbness is reduced or gone. They feel better, but you must retest, and we'll talk more about it later, because now they may have 3 antibodies elevated. It's not enough to cause a symptomatology, but the mechanism is still going on. So you always want a biomarker to start with. That's why we do these tests, is to identify where we're going to focus our attention. And then you retest to show that the temperature gauge is coming down. You know, I used to say this a lot. You know, Mrs. Patient, 2 ways to measure the temperature in the engine of your car. One way, the hot light comes on the dashboard. You've overheated. Pull over quick or you're going to burn up the engine. The other way is some cars have a temperature gauge, and you can see the thermometer slowly climbing towards the red zone, which gives you a window of opportunity to do something about it before you overheat and have to stop life, you know, before you get pain. That's one of the values of these tests, is the world of predictive autoimmunity. And we'll talk a little more about that in some of the case studies that we're going to show you. But the rule was test, don't guess. Now, how did I get involved with Vibrant? I think that's a good story because I owe it all to Michelle Ross, who's our Director of Clinical Services. She called me in January of 2016 and said, "Did you see this study?" And I said, "No." And she sent it to me. It had just come out. And she said, "It's from Dr. Murray and others." Murray. So in the world of celiac disease, and some of you may know that I've been speaking about wheat-related disorders since 2008 on stage as much as I can. There are 4 experts in the world of gastroenterology. I call them the 4 horsemen of celiac disease. There is Alessio Fasano, now at Harvard, used to be at University of Maryland, Peter Green at Columbia, Stefano Guandolini, University of Chicago, and Joe Murray at Mayo. And Dr. Murray was the one that wears bow ties, horn-rimmed glasses, leather patches on the elbows of his sport coats, you know, a real geek, and just the nicest man. And his papers always are so clinician-friendly to read, with recommendations and guidance for the clinician, not just a download of the science, but really clinically relevant papers. He's one of the 4 horsemen. So when I saw that Murray was the lead author on this study, or this is his team, it gave me interest right away to read it. And they talk about a new era in laboratory medicine. And I thought, well, what does that mean? A new era in laboratory medicine. They identified a technology that's giving 97% sensitivity IgG, 99% sensitivity IgA, 98% specificity IgG, and 100% specificity IgA. And I said, what? Because I knew this for years, but nobody was talking about it. You never ask your lab rep, what's the sensitivity and specificity of your test? I never heard one of my friends ask that question. I never asked that question because I was grateful to have specialty labs checking heavy metals, checking bacterial counts in stool analysis, measuring markers of poor methylation. You know, I'm really grateful to have these tests that we can do. I never asked about sensitivity and specificity. And when you do, you find out some of these tests are in the low to mid 70s. Most of them are in the low to mid 80s, which is pretty good, 82, 84%, but that means it's wrong 1 or 2 out of 10 times. Well, here we have Murray, one of the 4 horsemen, introducing what they called a new era in laboratory medicine with 97 to 100% sensitivity and specificity every single time. So I read that paper and I said, what? What? I immediately got on the phone because there was a laboratory referenced here. And I called the lab and I said, I'd like to speak to the president. So the guy gets on the line and I say, hello, this is Dr. Tom O'Brien. And he says, the Dr. Tom O'Brien? I said, well, I don't know, maybe, yeah, okay. Is this your test? Yes, I need to see this. The next week, I was up in Silicon Valley and getting a tour of their facility, which was beyond my understanding. You have to put literally a spacesuit on to go in to look at the testing equipment because it's silicone chip technology. No dust. It has to be a dust-free environment. And these huge machines, not quite, but almost 2-story high machines, 2-story rooms and these big machines, they kind of didn't quite look like fermentation tanks at a brewery, you know, so I'm kind of, oh, what's that? But not quite, but they're in that size category. And what I learned, so I've called it the 30-30 rule. 30 years ago, it took a 30 by 30 room, floor to ceiling computers at MIT to produce the computing power of this phone. Today, we all just take it for granted that I can open up an app here. I'm opening up the app Air Matters. And in the midst of 5 seconds, I can tell you that the air today, the air quality in Spiazzo, Italy, is 25, which is really good. That's low particulate matter. But in Chicago, it's 107, right? But I can pull up information anywhere in the world in 5 seconds. We couldn't have imagined that 30 years ago. If someone had said to us in 1995 or 1998, you know what, you're gonna have this little thing in your hand, kind of the size of a magnet, but you'll be able to pull up the entire encyclopedia, anything you want to know in 5 to 10 seconds. I would have gone, yeah, right. That's silicone chip technology. It's the newest technology. Now, I'm not a lab medicine PhD, but from what I understand, it's the newest technology that's out there with the highest sensitivity and specificity of any of the lab work that's available to us as clinicians. We started using these tests right away. And the results were just dramatic. Because sometimes we would be using the tests that were available to us that were really good tests, and yet the patient would come back with a negative on the wheat panels, but if they eat wheat, they get sick. And I just really couldn't explain that. I had to say, you know, that's just the exception to the rule, and I wouldn't apologize, but I'd feel bad. They spent the money for the test, and clearly this person has a problem with wheat. What was I not checking? Where was I missing it? It wasn't me, it was the test. So now we have tests that are 97 to 100% sensitive and specific. And Murray said the relative non-invasiveness, broad availability, and versatility of this technology makes it well suited for incorporation into routine healthcare, and also provides a promising new tool for biomarker discovery, meaning identifying the earlier stages before a person has killed off so much tissue, they've got organ dysfunction, and then eventually get a diagnosis of an autoimmune disease like celiac or like Hashimoto's or like MS. That this is the world of predictive autoimmunity. And that's what Murray and his team was saying here. So, you know, we know that there are many different types of wheats. There's a number of different types of gliadin, but most laboratories only check alpha gliadin. The few that are comprehensive look at alpha gliadin and deamidated gliadin for a wheat-related disorder. But we know there's over 50 different toxic immunogenic peptides. Some papers say 60, 62 that have been demonstrated to be immunogenic. So this test from Vibrant, called the Wheat Zoomer, I don't know what that is, it popped up on my screen to get that out of there. that it includes testing the non-gluten wheat proteins. And I'm sure that you're getting information about this test from other presenters. So we aren't going to go into a lot of detail on the foundation of the test, but I just want to show you of all of the different markers that it's looking at. And here are the markers for intestinal permeability that are included in the same test. And so you're looking for leaky gut and for the most powerful trigger, according to Fasano, of leaky gut. Remember, it's bacteria, LPS, and gluten. So you're identifying the two most powerful triggers of leaky gut in the same test. Do I have leaky gut? And the most powerful trigger that's been identified so far. Now, in looking at, I want to give you a couple of pearls here because many docs don't know about what they're looking at with these fusion peptides. When a compound gets into our body that is really not supposed to be there, it can bind with our tissue. When it binds with our tissue, like gliadin can, or deamidate gliadin can, and it binds to our tissue, it's called a neoepitope. It's a new epitope, something different. And your immune system can say, what the heck is that? So I just want to give you a little bit about the tissue transglutaminase and deaminated gliadin neoepitopes, as fusion peptides. So here's a paper that came out in the Journal of Immunological Methods. Each year of delay in celiac detection is associated with a significant increase in medical care costs. Its correct diagnosis and early gluten-free implementation can lead to considerable decrease in morbidity, mortality, and improved efficiencies in both economic and medical resources. Meaning, the earlier you can identify if a person's on the spectrum of celiac or a wheat-related disorder, the less morbidity they have. All right, that makes sense, but sometimes we don't think about that. There's a significantly higher positive activity when you include checking tissue transglutaminase neoepitopes, IgA and IgG, more so than if you're only checking tissue transglutaminase. Meaning tissue transglutaminase is what we initially looked at to identify celiac disease, but if you include in that test the neoepitopes, you detect a significantly higher number of people because you're detecting it earlier. Comparing antibody activity is a reflection of intestinal damage. Tissue transglutaminase neoepitope, IgA and IgG, and those antibodies correlated better with the degree of intestinal atrophy than tissue transglutaminase. Because so many doctors just look at tissue transglutaminase, oh, you don't have celiac disease, don't worry about that. But now we know if you've got antibodies to this neoepitope, these get elevated 7 years before a diagnosis of celiac disease. They're an earlier biomarker with 97 to 100% sensitivity and specificity. So here in the summary, in this paper in the Journal of Immunological Methods, what they talked about is the sensitivity and specificity of tissue transglutaminase in the pediatric literature. They did a literature review and they found it was greater than 90% for tissue transglutaminase. But when you look at the tissue transglutaminase neoepitope, it's 98 to 100% for sensitivity and 93 to 96% on specificity. So it's better. And when you can include both, you're being more comprehensive. Why wouldn't we want to do that? And in this paper that just came out last year from the British Society for Immunology, screening the available pediatric literature said the same thing, that when you include the tissue transglutaminase neoepitopes, you get higher sensitivity and specificity, which means less false negatives. And you're identifying earlier on the scale that someone is heading down that path, because elevated antibodies are never neutral. If they're elevated, by definition, they're causing tissue damage, right? So I was asked to just say a couple of words about this test, the wheat zoomer for intestinal permeability. One of the mechanisms that's so cool in this test, besides the sensitivity and specificity of the zonulin and the actin and the lipopolysaccharides, which other labs also look for, they include zonulin levels. And if you look at the literature on zonulin, most of the research on on intestinal permeability markers are zonulin levels, not zonulin antibodies. There's no argument from immunologists that zonulin antibodies are accurate representations of increased zonulin levels for too long a period of time. Everybody agrees on that. But when most labs do not look at zonulin levels. Why? Because the lifespan of zonulin is between 4 minutes and 4 hours. So depending on when you do the blood draw, you could easily miss an elevated zonulin level because the lifespan was between 4 minutes and 4 hours, and you did the blood draw 10 hours after they had the increased zonulin because of what they ate or whatever the situation should be. So once again, though, when you have a test that includes both the antibodies and the zonulin levels, it's more comprehensive. You get a better chance. Now, here's the paper that Fasano published in The Lancet in 2000, identifying zonulin. I thought I'd throw that in there so you can see they've been looking at this for over 20 years. And here's a paper from 2009 by Fasano's team talking about even when you have what are considered good bacteria, when they're out of range and the ratio of bifidobacterium to lactobacillus is out of range, the zonulin pathway can be activated. So that's a validation that the intestinal microbiome, the third in the 5 pillars of the development of chronic inflammatory diseases, can be the trigger for the development of permeability. The patient's diet may be clean. It might just be the microbiome that you have to address. Here's Fasano's paper that talked about over 50 toxic epitopes of gluten and that the different pathways, and I wanted to show you this one because the one in blue, these are gliadin motifs, and it's the ones in blue that activate zonulin release. All humans activate zonulin release when exposed to gluten. All humans. So that would mean everyone who's listening to this today. And I just want to throw this one in here for you to think about. When you get positive zonulin markers on these tests, zonulin analogs also modulate the blood-brain barrier, not just the intestinal barrier. So just keep in mind, anytime you get a positive zonulin biomarker on a weak Zoomer, please consider the Neural Zoomer Plus. Looks at 48 different antibodies in the brain because they're likely, if they've got leaky gut, they've also got leaky brain. Just test and see what you come up with. And I'm just showing you here a little bit of the anatomy of the blood-brain barrier. And when you're testing for leaky gut, you also are testing, because those antibodies are in circulation, they may be causing a inflammatory cascade in the blood-brain barrier. And on LPS, I just want to give you these pearls so you can think about them. How does LPS get into the bloodstream? Well, the ways that I've thought of, there may be others, certainly through the oral cavity, certainly through an open wound, septicemia, lipid raft transcytosis, which is why keto diets can be dangerous for people, or paleo diets, high fat diets, which are good, really good for some people, but not if they have elevated LPS levels, because via lipid raft transcytosis, you're increasing LPS levels in the bloodstream when you eat more fat. Air pollution and pathogenic intestinal permeability are the markers that I can think of that may allow LPS to get into the bloodstream. And I just wanted to show you how important vitamin D is. I often talk about leaky gut as the Panama Canal, you know, that the gates open, food molecules go in, the gates close, the immune system checks it out, the next gates open, food molecules go down a little further, the gates close, the immune system's checking out. This is all in the intracellular space. And vitamin D controls the gates of the Panama Canal, opening and closing. So if you have vitamin D insufficiencies or deficiencies, it certainly may be contributing to the development of leaky gut for that person. There's more to it than just vitamin D. We go through all of that in our CGP program, but I just want to make sure everyone knows about the essential nature of vitamin D. And all these topics are in my books, and I'm not here to push the books, but they're on Amazon, and they're in these languages if you want to check them out in much greater detail. And I put this one in here just so that you know Once again, well, 7% of treated healed patients were still positive to tissue transglutaminase IgA. 27% of unhealed celiac patients were positive tissue transglutaminase IgA. About 3/4 of the treated unhealed celiac patients were negative. That tissue transglutaminase is not an early marker of unhealed celiac disease. That it's the biomarker that we knew of in the early 2000s and 2010, but now we know, well, I'll get to it in a minute, the loss of the immune response to novel epitopes combines sequences of deaminated gliadides, deaminated gliadins, and tissue transglutaminase show a promising non-invasive predictor for healing in treated celiac. This was an abstract presentation at the American College of Gastroenterology conference in 2017. They were talking about the neoepitope of deaminated gliadin and tissue transglutaminase of being a better marker of untreated or treated, of untreated but not healed celiac disease. And so that is the Vibrant Wellness, and I'm going to stop sharing this screen here now. That's just kind of the blitzkrieg I wanted to give you of the overview. Michelle?